chairwoman, the chairwoman.
For the chairman. TV and AMR is an aside from our institution, you know. All right.
What is the session about? Making
Diagnostics.
accessible. So we have Marguerite.
They're all there, no?
Only
Pedro,
Marguerite.
I don't really know.
Is the guy, the one that is sitting next to Marta?
Okay, good.
Oh,
This
it's so
is
easy if
not
this lady doesn't
immaculate.
come, huh?
It's not such a big problem. We just need to ask more questions. It will all be fine. Is there somewhere to put the microphone on, or how does it work? Do you put it on, or?
Don't play with it. I think we are 1 minute to go. Okay, I would say let's get it started.
Is she called Immaculate Cathura, isn't
Cathura. Or Cature. Cature. Should I close the door?
Yeah, I can post it. Okay, everybody, hello. We are going to start on time so that we can finish before time. I'm very happy to co-chair this session with Alberto. I'm just going to briefly introduce myself. My name is Katarina Kranzer. I'm actually based in Zimbabwe, but for a lot of people presenting here, I've also worked quite closely with them together. I'm from the London School of Hygiene and Tropical Medicine and the University of Munich. Over to you, Alberto.
Thank you. Good afternoon. My name is Alberto García Basteiro, and I work at the Barcelona Institute for Global Health and also at the Manisa Health Research Center in Mozambique.
Our session today is going to span different issues around diagnostics and making diagnostics accessible. And we are going to start with a point on the program, which initially wasn't on the program, which Celso Cosa is going to present from INS in Mozambique on the CAP-TB study. One sub-trial in here, which is called CORE, and he's going to look at implementation of near-patient testing using the MolBio platform, the CORE trial. Over to you, Celso.
Okay. Good afternoon, everyone. I know this is the last session of the day, but I hope you can stay awake during the session. I have no conflict of interest to declare. This is the outline. So a little bit about the TrueNAT testing system. I know that these have been discussed in some of the other sessions during the day, but I will just give some of the basic. So this is the a PCR-based system. It detects MTB complex. It's compact, portable, and can run on batteries. It's ideal to use at the sites where you see patients. When you look at the picture on your right, you can see the different components that start with the extractor that usually runs for 25 minutes, and then you have to run the TrueLab PCR analyzer, where first you have to detect the bacteria, and then you can also look for reef resistance. The limit of detection is 100 CFUs per ml, and finally, this was endorsed by WHO in 2020. The CORE trial, this is a pragmatic randomized control trial to assess the implementation of the MolBio. The trial happened in Mozambique and Tanzania, in Mozambique with the INS and CISM, and in Tanzania with the IHI and NIMR. The primary objective was to evaluate the effect of testing using the TrueNAT and the rapid communication of results in primary healthcare clinics and treatment initiation for microbiological confirmed TB at 7 days from enrollment. We had in total 29 clinics, 14 clinics in the control arm. In those clinics, they had the capability to do smear microscopy, or they would refer samples to our off-site testing facility. In the intervention arm, those were the facilities where the TrueNATs were located, basically. If we move now to the results, we can see here the baseline characteristics of the participants divided by intervention and control arm. We can see that there is a fair distribution when we look at recruitment sites between intervention and control. Basically, randomization works in terms of allocating equally recruitment sites, gender, also a good distribution when we look at age groups. When you look at cough by design, we can see that there's also a fair distribution, and we can find more participants with cough more than 2 weeks by design, because this is one of the criteria to be a presumptive case. For the HIV status, we can see that on the control arm, we had a little bit more of positive results. And finally, ART in years were 5 years median in the intervention and 7 years in the control arm. Looking at the primary outcome results, we can see in the graph that in blue, the intervention. So basically, a higher proportion of participants started TB treatment within the 7 days after enrollment when we look at the interventions versus control arm. And we can see that clearly that the incidence rate ratio is 1.5 with the confidence interval above 1. Looking again at the median time to treatment initiation at the Kaplan-Meier between microbiology confirmed pulmonary TB and clinical diagnosed TB, we can see in purple that for the intervention arm, most of the participants at the microbiology confirmed would start TB treatment far ahead 7 days of the primary outcome. When we look at the control at the clinical diagnosed TB, we can see that the time would extend a little bit, but we still keep this advantage of the participants on the intervention arm starting treatment earlier when compared with the participants in the control arms. Let's look a little bit on the performance of the mobile in terms of first errors on the extraction stage. We can see here that from 2,000 samples, we only had 135 errors. 4 samples were not rerun. From the rerun, we can see that almost all the samples, only 18 did not have a final result for the participants. When we move into the PCR stage, looking first at the true prep results, we can see here that from again 2014 samples, 22 samples were not repeated. We had like errors and invalid samples that were repeated, and we ended with 71 invalid plus 4 samples with the error that we're not able to provide the results. Again, the rate here is low. Finally, if you look at the PCR results for RIF, we can see that from 150 MTB detected that we needed to look into resistance for rifampicin, 6 were not tested, and we had 14 determinate results for RIF plus 5 errors. Here we can see a higher rate, almost 1 in 2 samples not having a final result for the participants. Moving now to the conclusions, we can see clearly that on-site diagnostic capabilities accelerate TB treatment initiation. Same day kind of test and treat strategy was successful achieved and reduced the delay in started treatment and improved patient care. The majority of true PEP invalid errors were solved by repeating the test. And finally, 30% of the RIF samples resulted in indeterminate or error results, and asking participants for repeating samples is logistically difficult. Thank you. Before ending, I have to say that this would not be possible without the sponsor fund, without the funder, EDCTP. We have also to thank the participants and their families for giving their time for the study, and also the staff from the clinics and from the research team that made this possible. Thank you.
Great. So we are going to allow for a couple of questions. There is afterwards a plenary discussion, but I think if there are specific questions on the different presentations, please go ahead.
Yeah, thanks a lot for the presentation. It's quite clear. I just wanted to confirm, the sputum you used. Was it the same sputum you used on both the TrueNat and the GeneXpert? And if not, how does that impact on the results, given that sputum quality might differ from one test to another test?
Okay, thank you. Should I take all the questions or I just?
Okay,
Kelso. Maybe I will have one more.
Thank you, Zeros, for the presentation. Willy Sengover from Makerere University. My concern is about the rifampicin indeterminate. The rate is high, about 26%. And this being a study, I think you have the comparison results with the GeneXpert. But in real life, that leaves you with the no answer for rifampicin resistance. And it's not only in this study, even the studies we have done in Uganda, the rate of rifampicin indeterminate is high. What could be the cause of this? And how do we deal with this as we're trying to get the value for the test, but we don't want to miss rifampicin resistance in these patients?
Okay, thank you. Thank you for the questions. So maybe I will go back a little bit to the design. I don't know how to. So here I have to clarify that basically we had two separate arms. In the intervention arm, we would test with the TrueNat only and no comparison with GeneXpert, while in the control clinics, samples will be, if smear was available on site, would start with smear and then would have an expert. So no comparison within the same arm, just to clarify if this was not clear. And so basically that responds to the question about quality of samples, but that's also related to the question about RIF, because here the indeterminate results basically also show us that I would say that this is the probability that the bacterial load is low, because you need for the RIF, very similar to the gene expert, you need several sequences to get that, several inserts to get that result, while it's not the same to detect the bacteria, like for MTB, to detect the MTB complex. So basically, I would say that part of the reason for indeterminate results would be the low bacterial burden in those samples.
But it's certainly true that the proportion of indeterminate results is higher than what you would expect in an expert testing scenario. And that's certainly something which I think the manufacturers need to address, and hopefully they will address that. But they are aware of it. We have obviously shared these data with them.
Yeah, Stefanie Mambosl, we did a similar study in Germany, and we had similar indeterminate problems, and sometimes what helps is dilutions or additional cleanup, which of course you cannot do in a programmatic setting, but that may explain part of it, that the purification is working for the primary detection PCR, but not essentially for another PCR. And we also seen that because what we did is deplex on these extractions, and we had the same thing, that to get a good sensitivity performance, you have to do an additional cleanup. And that may explain some of this. And we also reported it back to the manufacturers.
And just to say, I mean, we have done some, but not all of them have had repeat results. And even when you ask for another sputum sample where you're hoping you would have a higher bacterial burden, often then the second sputum sample might not be TB positive, then you can't even go on to a second test, or you have the scenario that even the second RIF test is again indeterminate because they are on the lower edge of the bacterial burden. Any other questions? I just have to say the one thing which I have taken away from this trial, we can start TB treatment on the same day. Yeah, I mean, the 7-day cutoff was an arbitrary cutoff, but it is possible to start TB treatment on the same day and make people wait for the results. The results take less than an hour. Even the people who had negative results, 98% of people actually waited for the results. So only 2% left. People have an interest in positive and negative results, and I think that's important. As TB community, we often only think about the positives, but actually saying somebody doesn't have a disease is sometimes also helpful. So I think that is an important part of the puzzle, and we often don't really consider that very much. And there is a qualitative poster, it's poster 310, which goes into more detail about the patient experience about it. Thank you very much. I hand over to you, Alberto. Sorry, another question.
Thank you, Tom de Croo from Antwerp. Did you look at the trend of TB notification? Did the employment of those tests on site increase the TB notification by district or by region?
I don't think we looked at that general notifications.
No general notifications. We didn't look at general notifications, but you will have seen we have done it, not just a proportion, but an incidence calculation, very much informed by the EXPEL trial, because there was the question, maybe you just test more, your kind of level where you test becomes lower because it's easier accessible, and therefore you diagnose more people, but maybe proportionally the yield goes down. But actually both the proportion increased and the number of diagnoses increased with the incidence ratio of 1.5.
And the second question, did you see any effect on diagnosed TB? Does not bacteriology confirmed, because I can also imagine that the more we have access to these molecular tests, the less that clinicians are inclined to still use their clinical skills and take the balancing harm and benefit of of making a clinical diagnosis of TB?
So I don't know, Kelso, if you
Yeah,
can bring
it
up your
will.
slides again.
Yeah.
We have to move
Yeah.
on.
So, I have on my screen.
Just a sec if you want.
Thank
yeah, good second.
Here it is,
Yeah.
yeah.
So when again we look at the clinical diagnosis between intervention and control arm, we can see that again, I mean, the conclusion we came was that again, having the tool there would give more confidence to the health professionals to start earlier, even in the intervention arm again.
This is time to treatment.
That's it.
And you see that double as many people were diagnosed with clinical TB. It's 61 versus 29 in the control arm compared to the intervention arm.
Okay, thank you.
Okay, thank you very much, Celso. This is the first time these results are presented to the public, so thank you very much, Celso. Exciting data. And now it's my pleasure to invite Dr. Marta Cosa to the stage from Mozambique to present on the rationale and the progress of the Exultant trial.
I'm not that tall. I have to put this down a bit. Good afternoon. My name is Marta Cosa. I am a medical doctor working at the Manhissa Health Research Center, Maputo, Mozambique. And today I'll be presenting to you a diagnostic testing algorithm for inpatients living with HIV, which is the TB-capped Exultant trial. So according to the UNAIDS global report, states that 39 people were living with HIV in 2022. And of these, 2/3 live in the African region. Stunning is that 630,000 HIV was responsible for 630,000 deaths, and of which of these, a quarter were due to tuberculosis. We all know that not only are people living with tuberculosis at an increased risk of MTB infection, but they also are a 20-fold increased risk of disease progression compared to HIV-negative patients. So this also leads us to a high in-hospital mortality of around 25% to 40% according to various studies in a meta-analysis. So various studies have tried to summarize the prevalence of TB in post-mortem, and one study by Gupta shows us that 50% of TB cases that died in hospital were not diagnosed before death. And also, a dramatic study done in Mozambique, my country, in a very big hospital, the Maputo Central Hospital, states that in a sub-cohort of 73 autopsies done on HIV-positive adults, 25% of them had TB as the cause of death. And an additional 18% also died of TB, but as a were not the main cause of death. And an alarming 20% of people who died from TB were detected by clinicians. So out of all of those who died of TB, only 20% were diagnosed by clinicians, which is quite alarming, which also takes us to look into other further strategies to help these people living with HIV. What are the available tools? So currently, the WHO recommends a 4-symptom screen algorithm based on 4 symptoms, which is cough, night sweats, fever, and weight loss. And these are further on led into a high-sensitive diagnostic molecular test, which is the Expert MTB-RIF Ultra. But this also has its challenges. A recent study done by Hamada states that it has a sensitivity, the 4-symptom screen algorithm has a sensitivity of 51%. So this means that almost half of these patients don't have symptoms but have TB. So we're missing out on those. And also, since it depends on a sputum sample, production of a sputum sample, a recent study also states that 35 to 50% they're unable to produce sputum. And remember, we're talking about people living with HIV hospitalized in a critical condition. Another available tool is the rapid urine TB-LAM assay, which is also recommended by WHO with the following criteria. He or she must have signs and symptoms of TB. They must be advanced HIV disease and also seriously ill. Although it's the most sensitive available tool that we have actually currently, and it's also cheap, and it has been shown a great impact in people living with in mortality of people living with HIV. Well, we don't see this case scenario. Why? Because it's not widely used. A recent study actually states that in a survey done in 22 high-burden African countries, 90% actually confirmed to have the policy implemented in country, but 50% don't confirm that they actually use it in the health facilities. So despite being cheap, it's not available, it's not widely being used. It's also very dependent on the observer who is reading the test. For who has done this Alirlam, they know that the first band is quite discussable. And also, it also depends on the complex eligibility criteria of which might not be feasible in the clinical context. So we're now looking into alternative samples, which could be potential novel diagnostic tools to address this challenge. When you look at the urine expert MTB-RIF, a study done by Lon really states out of the 473 HIV positive patients, 139 were actually diagnosed with TB. And out of these, we have an incremented yield of the urine expert MTB-RIF. So 49%, nearly half of these patients who were diagnosed from TB actually were only detected with the urine expert compared to the sputum expert. Also, another readily available tool is the stool sample. So the stool expert MTB-RIF Ultra, when we combine the Ultra on a respiratory sample and a stool with expert Ultra, it gives us an incremented yield of around 4% in people living HIV and also in children. And also, this article states that MTB was more frequently detected in children on stool sample by 26.1 compared to 23.4% on a respiratory sample. So this high burden of TB and the potential benefit of alternative samples have led us to the design of this clinical trial called Exultant. Exultant is a multi-center, parallel, individually randomized trial done in 2 countries, Mozambique and Tanzania. In Tanzania, we have 2 sites, which is Ifakara and Nimri, and in Mozambique, INS and CISM. So this study aims to evaluate or assess the impact of an expanded ultra testing on different specimens, such as sputum, urine, and stool, with additional TB-LAM, compared to the WHO guidelines that we all are aware of. The overall sample size is 1,172 participants, and its primary endpoint is to evaluate the proportion of participants diagnosed with microbiological confirmed TB that start on treatment within 72 hours of enrollment. And the primary secondary endpoint, because there are others, is to evaluate the all-cause mortality at week 8. So this trial initiated, although phasedly, in July 2022, and we hope to finish it off in December 2023. And so far, we have reached 70% of the sample size achieved, with one of the sites that have finished enrollment. Taking advantage of this large study, we'll also look into other potential tools, such as the C-reactive protein. So we'll look into the diagnostic accuracy of a C-reactive protein test, which is a fingerprint test, using the Lumira DX platform, as you see it on the screen. And we'll also be looking at the proportion of the Expert Ultra done on tongue swabs, which has already in some other countries been very much studied. So I would like to acknowledge firstly EDCTP as the funder of this trial, and the sponsor, FIND, and the sites, participants that have made this trial possible, and also collaborating partnerships such as Link and IS Global. Thank you very much.
Thank you very much. Any questions from the audience? Please raise your hand and yeah.
So thank you. With the justification, it's really about mortality due to missed TB, yeah? But the endpoint is about proportion of bacteriological confirmation. Could you comment on that? Why did you choose an endpoint that is not completely coherent with your justification?
So the primary secondary endpoint is to study the all-cause mortality at week 8. I don't know if that answers your question.
Okay, thank you.
So it's a secondary endpoint.
Okay.
Oui.
Yeah, okay.
Any other question? If there are no questions, thank you very much, Marta.
Thank you. Very interesting, and looking forward to hearing the outcome of the trial. Just wanting to have some insights as to how you were able to enroll so successfully during COVID. You started your study in 2022 and you're ending in December this year.
Yes, this was quite challenging in the beginning, I remember. But in the beginning, we started, as I mentioned, we started at a staggering, so some different sites started at different times. July was the official opening month, but some sites opened further on, such as Mozambique at CISM. We opened in September due to these challenges of COVID-19 impact on the hospitalizations. So further on, I mean, we have 70% of the target achieved so far. So I hope that this has not been such a great impact because of COVID.
One last question here.
Yeah, thank you very much. Really, it's very interesting work. So, what do you expect from this study? Okay, of course, it is 70% of your sample is already collected. So, what do you expect, and what would you tell us about your expectation? Thank you.
Well, firstly, I expect that we will finish the recruitment target by December 2023. And additionally, due to various studies and the background that it's available on expanded testing, using these 3 samples, including TB-LAM, I have no doubt that this will give us an incremented yield on microbiologically confirmed TB in these patients.
Perhaps I should add that this study will provide a lot of insight on what the best algorithm for this population of admitted people living with HIV will be. And we have to keep in mind that not all patients are able to provide the samples that are stated here, as Dr. Marta said before. So I think this will provide very valuable information to actually come up with the probably the best algorithm for this population. Thank you.
Thank you. Thank you very much. So I'm not sure if our next speaker is in the room. Yes. Great. Thank you very much. It's a great pleasure to introduce Immaculate Kathure. She is from the Ministry of Health and from Kenya. And she will give us really a bit of a reality check, because up to now you have obviously seen kind of data from clinical trials, even so a lot of these trials are quite pragmatic trials. But now we will get a bit more of an understanding, what does it mean to implement something like the TrueNat in a big TB program. Thank you very much.
Thank you. Good evening. And as mentioned, my name is Dr. Kathure Immaculate, NTP Kenya. And I'll be sharing with us our country experience on the TrueNat implementation. As we all know, one of the things that every country is currently grappling with is expanding the access to diagnostics and treatment for patients with TB. So I'll start by introducing what our key programmatic focus areas are and zeroing in on the second one and the first one. The first one is to optimize current TB interventions, ensuring that services accessible to the population with continuous quality improvement, point of care record systems, and targeted preventive therapy. The second one being adoption of new technology. And when we talk about new technology, we are talking about chest x-rays, we have molecular diagnostic tests, and then in addition to that, we have newer and shorter treatment regimens for TB. In addition to that, we have leveraging on universal health coverage, community systems, tailoring our interventions to subnational epidemics, engaging all providers and sectors in their efforts towards TB control. With that, I'll give a snapshot of Kenya being a high TB burden country with about 90,000 cases being notified every year, and a continuous notable increase in case finding across all the age populations for drug-sensitive TB. In addition, we also have challenges in DRTB surveillance for patients, seeing the decline that was noticed in the last 1 year. And then we also have an increase in the number of contacts that we're able to identify and initiate in preventive therapy and our TB-HIV collaboration services. So how does, in the background of that high burden for TB, what does our diagnostic landscape look like? So we have a total diagnostic establishment of about 5 health facilities that are able to offer line probability tests. And then we also have our national reference lab. We have about 211 gene expert equipment in the country, about 38 TrueNat equipment that have currently been deployed, with an additional 40 sites targeted for operationalization before the end of this year. We also are utilizing TB LAMP in 26 sites, culture and sensitivity. We have our old school microscopy sites. We have a pilot for ICRA in 2 sites, and currently digital chest X-ray with CAD software in 8 sites, and that is scheduled to scale up in the course of the year. So for us to be able to roll out our TrueNat, when we eventually decided to go that way as a country, we decided to assess our sites, because one of the things we realized is that we had to now rationalize the sites that were going to receive TrueNat, given that we already had expert as a molecular test that was operating in the country. So the objective of this was to assess our lab capacity infrastructure, looking at the quality management systems, our commodity systems, our M&E systems, biosafety practices, and what was currently existing in these facilities. Initially, we targeted 80 sites, and we used the GLI TrueNat site assessment checklist to be able to prioritize what facilities we were going to deploy our TrueNat equipment in. And then when we eventually decided to settle for 38 sites, the criteria was based on the site assessment report. And then we also have to go through an in-country process of approval and adoption through the committee of experts. In addition, apart from the lab capability, the infrastructure, and the commodity management systems, we also had to consider our lab staffing, and we had to make sure that the sites we deployed had a minimum of 2 lab staff that were working in those particular sites. Then once we decided that Once we settled on the 38 sites, we went through a process of staff sensitization, starting at the national level, and also all our other stakeholders. This is because we realized that at the end of the day, apart from the staff that are going to work in these facilities, the national staff that would oversee the implementation, we also had stakeholders that would help us to also ensure that there was mobilization of our patients to drive the demand and make sure that our quality improvement processes were well supported. So the program identified what we call super users. These are people who work within the facilities at county level, and they are trained and equipped to be able to offer quality support to those sites in case there is any need for troubleshooting. They also act as TUTs, we call them trainer of trainers, so that at the end of the day, they continually offer training, mentorship, and continuous capacity building to the sites in the course of operationalization. These super users were trained, and part of their skill capacity building was to monitor the instrument used, to be able to ensure there was reporting, to be able to provide mentorship and support supervision, troubleshooting, to be able to strengthen our reporting structure, and ultimately to support our panel testing scheme for quality assessment. So we went ahead and installed our TrueNat equipment. We had support from the National TB Program, our implementing partners, and the in-country agent for Molbio, that was the STEP Labs. They went ahead and supported us to ensure that at the end of the day, apart from installing the equipment, they helped us actually with capacity building and scoring the need to make sure that even as we are rolling out this equipment, we need to work with the right people, because an agent that is well equipped and well trained is actually a resource when it comes to deployment and capacity building at facility level. Then they also offered, apart from the theoretical training, they were also able to offer practical training sessions. The other additional advantage, and one of the things that Kenya prides itself in, is a very strong monitoring and evaluation system. So part of the deployment of the TrueNat data happened at a time when we were piloting our INTP project that was supported by USAID. And one of the things that I would say is we strengthened our data collection systems. Now we realize that as facilities expand their diagnostic platforms, there is need to bring together all those tests that the patients may be accessing and to be able to look at them from one central place, as opposed to having multiple reporting systems. For those that actually have rolled out GeneXpert, we know GeneXpert came with its own reporting system. Then we had microscopy, that was a manual reporting system. We have TrueNat now, we have chest x-rays, we have LAMP, we have LAM. And we realized that unless we were able to bring our data together, sometimes when a patient has accessed more than one diagnostic test, then the clinician has to do a lot of work to look at all the other tests that have been done. And this is when we decided to use our application programming interface to be able to connect to a central server where all our diagnostic tests have been are being uploaded. And currently, we would like to say that we have GeneXpert, TrueNat, AFB microscopy, and CAD4TB deployed at this level. And we are able to actually have clinicians access the data. We are also able to compare positivity rates for the same patient across different diagnostic platforms. And we hope that with time, we have adequate data to be able to confirm, to be able to assess the performance of the various diagnostic instruments. In addition to that, we also know that this will help us to improve our monitoring and evaluation system and to be able to track areas for future scale-up, even as we're expanding our diagnostic platforms. So what was the impact of rolling out our TrueNat? So one of the greatest impacts, or the immediate result we saw, was an increase in uptake for testing, and also an increase in the number of positive tests that we were able to realize. With out of these 41,000 tests, we had up to 10% positivity, which is way higher than some of the other tests that we had deployed previously. In addition, we are also seeing an increase in our ability to detect rifampicin resistance with a 2.4% positivity. This may not be optimal, and one of the things that we are trying to work on as a country is to improve our positivity rate by further strengthening our screening criteria to make sure that those patients that actually access the tests are patients that are likely to have TB. However, that does not mean we are leaving out anyone, but currently we are open to all the patients that have any symptoms as per the diagnostic algorithm. So what are some of the challenges we faced? So one was the issue of commodities. So when we have these new tests coming in and they have different components that constitute reagents, when it comes to delivery, we find that some of the components are packed with different expiry dates. So you'll find a buffer has a shorter expiry date than the other commodities. So what happens is that you run out of one, and ultimately you're no longer able to continue testing. And if planning and commodity supply chain is not strengthened, then there is also a possibility of expiries as we wait for the additional commodities to be brought in. Then there was also the issue of monitoring and reporting. Then there was also the issue of multiple SOPs available at site level. So healthcare workers now have to grapple with thinking about SOPs for TrueNut, SOPs for expert, SOPs for chest x-rays. And one of the things that the program has done is to coalesce all of them into a diagnostic algorithm and then highlight the tests as one of the options that will be there. However, for the lab staff, they also have to figure out how to collect the samples, how to package them and ship them differently. Then we also had issues around the samples, where the samples were not well eluted, especially the diluted, especially the thick samples, the liquefaction buffer, the fact that it was not consistently used for the right purposes. There was a short sample incubation period, and the flash protocol was not consistently done in one of our facilities. The other challenge we've had is indeterminate results and what to do with them. And this, as we have seen, as we have scaled up our capacity building, we've seen this declining over time. And then connectivity delays to ensure Tibulim's functionality as we try to deploy all our tests to be able to be available in one reporting platform. So what are some of the things we've done? So one of the things that we are working very closely with is the in-country agent to realign our supply chain system so that the different components can be available with different, with as close as possible expiry dates, and to also fast track importation of additional components in case one of them runs out. Continuous mentoring and capacity building, strengthening and reviewing our SOPs even as we continue operationalizing, and then taking a lot of feedback from our facility level staff to be able to strengthen that, and then strengthening our monitoring and evaluation, diagnostic algorithms, and also to scale up demand at facility level. With that, a big thank you to all the teams that worked with us during the rollout, and to also share with other countries that at the end of the day, yes, it's possible, yes, it's important for us to scale up the newer tests. However, we need to continually pause and reflect and take our lessons, because one of the things that's happening is that as more and more tests are becoming available, there is need for countries to think where to place these tests, how they relate to one another. Can they be used sequentially? Do they have to be used in parallel to one another? And at one point, we'll also have to look at our quality improvement processes and make sure that they are strengthened and they're in place. Thank you.
Thank you very, very much. That was extremely informative and has really resonated with a lot of the issues we have seen as well. I just want to congratulate you about bringing all of the different assays together on one big, it's not really laboratory information system, but together in a platform, because obviously that has been a big issue also with the Gene Expert, but being able to even have smear microscopy is superb. I will allow 2 questions so that we are not running late. Any questions from the floor, please? Just shout out.
So in general, TrueNut has more steps, pipetting steps than How are you seeing the error
Okay, so TrueNut has more pipetting steps, and therefore the question is that one of the reasons why there is an increased error rate? But I think you have shown that you can get on top of that. Please.
Yes, so yes, that was one of the things that we experienced as we were deploying. And so one of the components that we've really strengthened is continuous mentorship and capacity building. And that's through the super users, we're able to offer one-on-one support to all our sites. And as a result, we've seen a reduction in the error rate. So yes, that's one of the things that countries will have to grapple with as they're deploying TrueNut.
Thank you very much. Any other questions? One more allowed. There's one behind there.
Congratulations on your rollout, and also very impressive about getting all the results on one system. The number of TrueNut tests done and the positivity on TrueNut, an overall increase of TB case finding, because I wasn't so sure what.
Yes, so one of the things that we are realizing is an increase in our overall TB case finding, and okay, let me take that again. Yes, we have seen an increase in overall TB case finding. And looking at the type of TB cases we are notifying, there's actually a notable increase in the number of bacteriologically confirmed TB cases being notified as we scale up and expand our diagnostic platforms. However, loving the children, always saying that, yes, we are leaving some populations behind, and one of the things we're trying to do as a country is to see, as we're getting newer tests, then how do they take care of the vulnerable population? So that's the children and the persons living with HIV and AIDS.
Thank you very much. So it's my pleasure to introduce Marguerite Masinga Loembe from the African Society of Laboratory Medicine, who's going to tell us a bit on the translation of the research results into national policy.
Thank you, and at this time of the day, I think I need to say good evening to everyone. So as has been mentioned, I'm Senior Science Manager with the African Society of Laboratory Medicine, or ASLM. I have no conflict of interest to declare. I will just mention that I'm also the chair of the Stop TB Partnership Global Laboratory Initiative core group. And so, yeah, my presentation will really take over from the previous one, looking really at how we can improve access to new diagnostic tools by really strengthening the bridge between the diagnostic pipeline, research and development pipeline, and adoption into national policy for scale-up at country level. And so we should not lose the sight of our goalpost, which is really to achieve early diagnostic of tuberculosis, including universal access to drug susceptibility testing. So yesterday, the global TB report was released, and we see that we are picking up from the negative impact of the COVID-19 pandemic, with now 7.5 million TB cases detected. However, out of these, a little bit less than half of them have had access to WHO recommended rapid diagnostic test. That is globally, and for once Africa is like 1% above. So globally it's 47% and Africa is at 48%, but that is still only 1 in 2 persons accessing those tests. And for MDR-TB specifically, only 2 out of 5 cases had access to diagnosis and were initiated on treatment. So there is still work to do. And so those words of the WHO Afro director are still resonating, that Africa is still recording a significant gap between the estimated number of TB cases and those that are diagnosed. And we risk missing those major milestones if we don't really expand further access to those rapid diagnostic tools for tuberculosis. And so how should we aim to do that? So I will really paraphrase the word of our colleague, Professor Abdoulaye Jimde this morning, about really emphasizing the focus on dissemination, and where he was advocating for one budget line for dissemination. Actually, as part of the TB-CAP consortium, we have dedicated a full work package on dissemination. And so we have the different studies which are being performed under TB-CAP, to close the gap and increase access. And so two of them have been presented by the previous presenter here. We have the core trial, we have the HIV trial, we also have the XDR trial looking at the ultra system of the gene expert. And so we have, as I was saying, a full work package which is led by ASLM and which really aims to facilitate policy change and inform implementation strategies. And for that, it's really reaching out and reaching early, even as the studies are being initiated, to really raise the awareness. And how do we do that? So this is a bit of a theory of change, so to speak, where we have the diagnostic research and development being performed. But at the same time, we see how we can really fast-track adoption into global policy. And from the global policy, how can we fast-track adoption by Ministry of Health? Really making sure that those global policies are being made context relevant and adopted into national policy and country work plan. And so so as to expand access not only at the central level, but also decentralization and taking really the test where it is needed closer to the patient. And the three main objectives are to inform translation of finding into the national policy, provide consideration and best practices for implementation, and really support country scale-up of molecular tool at the peripheral level. The way that we do that is really by engaging closely with end users and stakeholders, so the community. And the platform that we use is called the Laboratory Community of Practice for Strengthening Lab Network and System. And I'm very proud that I managed to say that in one go. I'm always stumbling. And this is funded by the Bill and Melinda Gates Foundation. And really the LabCop, that's the nickname. The LabCop, as we call it, is really focused on the diagnostic cascade, but also the lab systems that support it. And we approach the diagnostic cascade and the system as holistically and comprehensively at country level. So it's not disease specific, it's really all over. And the way we do that is engaging with Ministry of Health designated country team. Those teams are multi-sectoral. So the entry point is the lab directorate. So it's really the governance at the highest level of the Ministry of Health for laboratory matters. And we do engage also, we have representative from the National Public Health Lab. We do have from the disease control program, so we have HIV. That was a starting point for the LabCop. Nowadays, we have also TB, we have COVID-19 response entity. We do have also clinician, M&E officer, and others depending on the need of the LabCop. And the LabCop is multilingual. We do have country team in English-speaking countries, but also French-speaking and Portuguese. The Lusophone country have joined recently. We have, for example, Mozambique, but we also have Sao Tome and Principe, which are part of the LabCop. And so as part of a different system that support the diagnostic cascade, for the purpose of TB-CAP, we are really focusing on the policy and regulation aspects. And all those country teams are linked together through a social media, notably WhatsApp group. And it's really the principle, the basic principle is that there is a good idea worth sharing. And for example, all the nice work that has been done by Kenya Ministry of Health and TB program, how can we ensure that this is disseminated wide and far and adopted by other countries as well? And so to raise awareness, we have different dissemination means that we are using. What I would call the window of the LabCop, the one which is more widely known are the echo sessions, which are organized once, twice, maybe 3 times per month, depending on the topics and the period. And though the echo session were at the beginning dedicated to the LabCop country teams that I presented, they are open. And so we do have people joining not only from Africa, but you can see on this map that we have people reaching globally to attend those echo sessions. And in the scope of TB-CAP, we are setting up really regular sessions to present what I would call the ecosystem around rapid diagnostic tests. And for example, our most recent echo session was really dedicated to the WHO standard for universal access to rapid diagnostic tool. So it's really setting the stage where the research and the finding of the research will be adopted and how they can be relevant to the wider ecosystem. We had one also, just to mention LAM, from the study teams involved, because you know that when we are taking the diagnostic outside of the laboratory, then how can we ensure that we have quality assurance in place for the testing being done at the bedside? And so far, we've done 5 webinars in the scope of the TB CAP work stream of ECHO session. We also do have publication, and last year in Q4, we had a special issue of what ASLM calls the Lab Culture magazine. So this is really dedicated to the stakeholders, laboratory, but it's kind of this is not peer-reviewed, right? This is really disseminating experience from country and the perspective from the countries. So we had a special issue on expanding the diagnostics toolkit and really putting the emphasis on the need now to recover from the negative impact of the COVID-19 pandemic and refocus on TB diagnostics. Another kind of way we use to disseminate the significance of the research is to organize a special webinar as well, satellite session, because the LabCop country team are coming together on an annual basis. So the 21 countries are coming together alongside the stakeholders, the donors, so we have WHO, we have the Global Fund, etc., to really discuss the latest development as far as diagnosis is concerned. And really, we are supporting them to elaborate their country work plans. So last year, we organized a session from TBCAP, again, where we really aim to share early results from the implementation trial of expert, the GeneXpert Ultra cartridge and the early findings that we had that came out. And really, the aim here is really to support operational aspects. And so really looking at practical items such as, can you use residual sample for Expert Ultra? So these are really questions relevant to the bench and the end user. How do you comply with manufacturer recommended old time? And if you exceed the old time, is there an effect on performance? And what is the yield and turnaround time of DST result versus the standard of care? So those were findings that were discussed by the study team with the LabCop community. And we had a huge participation with more than 70 participants on location, 180 true webcasts. And this is on YouTube, the ASLM YouTube channel, so you can access it and if you want to listen to what was shared at that time. We also had a partnership with the USAID-funded Stop TB partnership introducing a new tool project, which really looks at early implementation of TrueNAT. And so Kenya was one of the early implementer, but we also had the opportunity to learn from the implementation experience from Nigeria, DRC, and also Zimbabwe. So how they really were kind of positioning the test for maximum impact. And that experience was shared with the LabCop country team, because as I'm saying, during this annual meeting, we are also supporting them to elaborate their country work plan. So they could already have access to all those insights and best practices. And for those who were interested in adopting and scaling up the TrueNAT, they had something to chew on, so to speak, to put into their country work plan. And this could also feed into their funding request. And for example, the Global Fund proposal, we've seen that many countries went ahead to introduce the TrueNAT. And finally, we are also aiming to guide implementation at the country level with the best practices. So still, we conducted interview with the introducing a new tool country teams and the national TB program, looking at key consideration around governance, regulation, quality, and biosafety. And just as Dr. Immaculate has shared the best practices here from Kenya, so we combine all those best practices from the different countries and how they can help those ones which are joining also into implementing TrueNAT. And so we had best practices related to joint stepwise national implementation strategies from Nigeria with all the stakeholders coming together. In Kenya, we had a best practice related, for example, to providing tax exemption for essential diagnostics to facilitate importation of the TrueNAT. Also, Zimbabwe used DNO diagnostic network optimization to inform placement of the instrument. So we are discussing how it is fitting within the algorithm. We should also discuss how it is fitting within the wider laboratory network, and where do you place it for maximal impact. And in that line, for example, Nigeria opted to use TrueNAT to expand access in hard-to-reach area where access to power was problematic because the machine can function on a battery. And they were also experiencing using TrueNAT as part of the mobile vans for active case-finding campaign. We learned about the TrueNAT super users and how they can contribute really to scale competency at country level for use of the instrument. And finally, we had also good insight from DRC. We know that DRC is faced with many outbreaks, and they were really looking at the opportunity to maybe evaluate multiplex testing on the TrueNAT platform for outbreak response. And so all those elements will be condensed into what we call a lab cookbook of best practices, which will be released in a month from now at the ASLM annual conference, which will take place in Cape Town. And this will help further with dissemination. And so what we aim to achieve at the end is to finalize that cycle. So not only to facilitate scale up and adoption, but at the same time, we have what we call the Lab Directors Forum, where the head of lab directorate from all LabCop countries are coming together and also trying to define what are their priority and the evidence that they need to inform scale up of rapid diagnostic tests at country level. And we hope that to be able also to feed back into the global policies and strategy for access to WHO recommended rapid diagnostic tool. And that is all. Thank you very much.
Thank you. I don't know, maybe just one question, because we are a bit out of time. So over there.
Thank you for a really interesting talk. I wonder if you have any thoughts on how accessibility to tests like hemoglobin test results might be improved when they don't fit in a vertical program and they are often unavailable, whether the approaches you've used could be applied in that setting.
Excuse me, which test? I didn't.
Hemoglobin test results.
So I will not comment on that specifically. That's not part of my expertise per se, but just to highlight that the fact, so I don't know if you're asking in the context of LabCop, but the fact is that, as I was saying, this is disease diagnostics, right? So we're looking at diagnostic testing and how to improve it, and whatever test is there, where it makes sense for the country to scale up. And so it depends on the request we get from the country also. So we will be supporting them in that line. And maybe where it would make sense, because currently we're providing also support for the elaboration of essential diagnostic lists. So in that scope, that's where it will fit.
Thank you. Thank you very much, Marguerite. Thank you.
Okay, great. So we are just going to put on Achilles Katamba's presentation. He unfortunately was not able to join us in person, but he has pre-recorded his presentation. He's from Makerere University from Uganda, and he's really going to report on a trial which is a bit similar, to the core trial, but has used the expert edge, which some people might know is kind of the only expert instrument now that the Omni has been taken off the market and is no further developed, which is essentially for decentralized testing. Thank you very much.
The effectiveness, implementation, and the costs and cost effectiveness of Expero TB strategy at community health centers in Uganda. Here we compared the Expero strategy, which was a multi-component diagnostic strategy implemented at 10 sites with the routine care. The multi-component strategy involved on-site molecular testing as the first-line test for TB, streamlined clinical, laboratory, and pharmacy workflows, monthly performance feedback, and it was compared to routine care, sputum smear microscopy as the first-line test for TB, referral of high-risk samples to molecular testing hubs. It was a cluster randomized trial, hybrid effectiveness implementation trial at 20 test facilities in Uganda. we looked at all adults evaluated for pulmonary TB from October 2018 to March 2020, and patients with rifampicin resistance were excluded from the trial. The EXPEL trial procedures involved a public randomization ceremony where we invited all the district people, health facility staff, and others to get involved in deciding who gets the intervention, the multi-component intervention, and who continues the standard of care. It was a pragmatic trial. Really, features we waived informed consent, no trial-specific changes to usual care, outcomes assessed using routine data sources, and there was minimal contact with health centers except during the initial training visit, plus quarterly site visits to resolve any data queries. The outcomes for the trial were primary and secondary. The primary outcome was number of patients treated for microbiologically confirmed TB within 14 days, and the secondary outcome was along the cascade of TB care, testing, number completing TB testing per national guidelines, number diagnosed with confirmed TB within the same day and 14 days, number treated and for confirmed TB within the same day and 14 days, and number treated all, including those confirmed and those not confirmed, same day and 14 days. On the primary outcome, number treated, confirmed, and treated within 14 days, the intervention multi-component strategy increased the number treated and within 14 days by 56% compared to the control arm. When we looked at the subgroup analysis for the primary outcome, we found that in all areas, sex, males were more likely to be treated within 14 days, females, HIV infection was similarly, except for HIV negative people where it did not achieve significance. However, it was still higher in a way. For the secondary outcome, really, along the cascade of care, testing according to national guidelines, received diagnosis of confirmed TB, treated for confirmed tuberculosis, treatment for tuberculosis. We saw that treatment for confirmed TB, we found that actually along the cascade of care, people who are in the intervention arm were more likely to be treated within 14 days as compared to those in the control arm. Really, there was high fidelity and improved quality across the cascade of care. For the cost and incremental cost effectiveness, found the cost per test was the same in both the centralized and decentralized, which is the cost per patient really treated was slightly higher in the decentralized testing. But when we looked at the incremental cost effectiveness, we found that ideally it was about 680 per patient treated within 14 days. We found that the number of TB, the volume of the patients at a clinic exceed 150 and above, then it may be better to use a decentralized model. However, clinics with lower volumes probably still a hub-spoke model, which is the standard of care, could be more appropriate. What lessons did we learn? We learned that using a highly pragmatic design minimizes bias related to conducting a study evaluating routine care outcomes. It is important engaging stakeholders at all levels ensures success. Our success was involved all level of care, from the National TB Program, from Ministry of Health, from the districts, from the healthcare facilities, and these all participated in the community randomization, which really was very fulfilling. And during the community randomization, 10 of the clinics which selected to be in the intervention arm got a one module gene expert. However, 10 did not get, and were promised to be given at the end of the trial, and we provided this platform at the end of the trial, which made people very happy. Here, systematically collecting data, longitudinal baseline data, is valuable to know the outcome trends and be able to effectively perform cluster randomization. Including implementation support is valuable, so we should not just focus on the diagnostic technology. I'd like to thank many people and acknowledge the funders. The National Institutes of Health Gene Expert devices were provided by Cepheid via FIND, and there are many members who have contributed to it, including the patients and others. Thanks to Aditya Katamanch for the leadership of this team. Thank you very much for listening.
Okay, thank you for the presentation. I don't know if Achilles will be is with us. Yeah. Okay. So if there's a question to Achilles, he will connect remotely. Welcome. Good afternoon, evening, Achilles.
Yes. Good afternoon. Good evening. Yeah, for sure. Yeah.
Thank you. Is there any question from the audience?
If there's no question, I take the liberty of the chair. I was just wondering, Achilles, if you could just touch on why in the decentralized system the patient level costing was like, as far as I remember, 20 USD versus 9 USD. What drove the additional cost in the decentralized system for the patient?
Yeah, what drove the cost for the decentralization as compared to the other? There are many other costs which were involved beyond the cartridge itself. In the decentralization, you could find that actually the staffing costs and others really to carry out these different tests was a bit higher than what would be involved by just sending. And the frequency and the timing of doing this and providing them timely was really another area that drove the cost of implementation. Yeah, those are some of the driving costs. Yeah.
Thank you. Another question here from Dr. Sengoba.
Thank you, Dr. Katamba, for the good presentation. I don't know whether I got that volume. It's more
Is it my network? I can't hear.
I'm going to repeat the question for you because I think we have a mic issue. So I think the question was, is the conclusion that sites with lower numbers of samples should do a hub and spoke model versus sites with higher number of samples should actually test on site? Was that the correct conclusion?
Yes, what we saw
Yes.
that if a site has got a volume, and that volume was for annual volume of about 150 and above sort of presumptive TB patients, I think a decentralized system works well. However, for lower volume sites of less than 150 per year, it may be better to really implement the hub spoke model, which is the standard of care. So it may not be that one size fits all. It may be that some of the lower volume sites you need to consider still the hub and spoke model.
Yeah, following that question, I wanted to get it clear whether that conclusion is driven by cost mainly, because much as even if, because we're advocating for access at the point of testing, at the point of care, and there are so many issues that might be incurred in the, and also requirements, taking the sample to the testing hub, returning the results. and then we are looking at rapid treatment initiation. Was that mainly guided by the cost? Are we trading off the cost versus access to the diagnostics?
Yeah, and as you know, these cost effectiveness models are based on probably the GDP of a country. So what may be cost effective in one setting may not be cost effective in another. Probably given what the Ugandan GDP was and looking at the thresholds provided, for now, I think it would be better to look at it in that perspective, that less than 150 may be. Probably you may lose more resources looking for that few patients within those low volume facilities than resources which probably, if you improved the hub-spoke model and you improved the riders and other people to return regular and others, may be cheaper and probably serve instead of having a machine there which probably may not have the right volumes to really make it cost effective in the given setting. So, yeah.
Okay, thank you very much, Dr. Katamba. Thank you. So we move to our last presenter, who is Pedro da Silva from the National Priority Programs at the NHLS in Johannesburg, South Africa, who's going to talk about the implementation, the experience on the implementation of the Expert XDR cartridge.
Hi, everybody. So I'm from the NHLS, and I really wear the implementation at scale hat for the NHLS. And so it's about implementation and the considerations for the Expert XDR incorporation into routine laboratory algorithms in South Africa. And so the context is really high burden of TB, HIV, TB co-infection, and drug-resistant TB, and also room for improvement in terms of the treatment success rates for drug-resistant TB. But the context of the lab service is that 5,000, just under 5,000 healthcare facilities are supported, all pathology discipline diagnostic needs by 233 laboratories, 71% offer Expert Ultra, and then there's a network of 15 TB culture laboratories. And so prior implementation of the XDR in terms of the workflow for rifampicin-resistant TB is that all testing was at via Expert Ultra at decentralized level, and where rifampicin resistance was detected. Further testing would then follow within the culture lab network of 15 labs on concentrated sediment with smear microscopy, first and second line probe assay, and midget culture in parallel, then followed by phenotypic DST. And in support of this, there's also varying collection practices across provinces, which complicates things. So some provinces follow a 2-specimen baseline collection strategy. The first one tested at decentralized level, and then the second one follows to centralized level, where rifampicin resistance is detected. But most provinces only collect a single specimen at baseline. And so where rifampicin resistance is detected, then the clients have to be recalled again, and those specimens are weighted, which then channel into the centralized testing. So there were a number of determinants that were considered for implementation. First is the intended use of the Expert XDR assay, and really that it's meant to be performed off residual SR treated specimen following Expert Ultra, and where rifampicin resistance is identified. But in order to achieve that, specimens have to have a minimum starting volume of at least 2 mils. And so that was an important consideration. But also that there were certain laboratory changes that had to be implemented in terms of reflexing requirements to meet the reflex processing window. In other words, all SR-treated specimens have to be refrigerated to meet the 4-hour reflex processing window for the intended use. And so other determinants were certainly the targets in terms of, these were identical to the existing first and second line probe assays, albeit 2 additional genes for isoniazid. Performance, essentially identical to line probe assays. We also did some modeling looking at whether there would be cost savings in terms of implementing the XDR using two approaches, either as an intended for use at decentralized level versus a replacement of LPA at centralized level. And when compared to the conventional workflow, there was on average between 64 to 69,000 US dollars saving per year. And so the other consideration was to run the Expert XDR is the requirement for modules with 10 color functionality, and only 10% of our modules have that ability. And then there were also considerations about limit of detection. The limit of detection for the XDR much higher than compared to the Expert Ultra, and as I mentioned, the variability in specimen collection practices across provinces. And so based on the determinants that we've mentioned, there were really three that did not favor decentralized deployment. First of all is meeting the processing window in a program that processes around 2.5 million Expert Ultra tests a year, the majority of decentralized labs being of high and very high throughput. And so the additional steps to refrigerate all the SR-treated sediments and also the QA aspects in terms of appropriate retrieval of those sediments where rifampicin resistance is identified for further testing. The other one is specimen volume, because the majority of our specimens actually range between 1 and 1.5 mils, which therefore meant that the intended use or direct reflexing would not actually be possible. And then without actually investing further resources in acquiring more modules with 10 color functionality, they just weren't sufficient for decentralized testing. So everything really was in favor of a centralized model and replacement of the existing line probe assays. And so the modified workflow for any rifampicin resistance detected at decentralized level then was channeled to the centralized labs, performed off concentrated sediment, and if any of the drug targets were unsuccessful or the test unsuccessful, since culture is also done in parallel, it's then repeated off the culture if culture positive. So to complicate things, in December last year, we took a bold decision to end almost 25 million tests of Expert Ultra and supplier dominance. And we introduced two moderate complexity platforms, Becton Dickinson's BD-Max and also the Cobus from the Roche. And so this added another layer of complexity for the implementation of the Expert XDR. In terms of that both BD and Roche platforms also now provide an isonized result. And you certainly can't reflex directly to the Expert XDR from residual BD or Roche treated specimen. However, since we had implemented this centralized model, it kind of fitted in conveniently that whether you have rifampicin resistance by Ultra or BD-Max or Roche, the second specimen is still channeled for XDR. Yes, you would get a repeat isonized result, but slightly increased sensitivity in terms of isonized, and then the just added layer that one would have to deal with discordant isonized results at the Expert XDR level. And so really, in conclusion, there were certainly cost savings, whether implementing either at decentralized or centralized level, but this was limited by generally specimen volume, most not being at least 2 mils, the insufficient number of modules with 10 color functionality, and also the diversification affected. And then just many stakeholders to acknowledge in terms of the implementation and also sponsorship for travel to be here. Thanks.
Okay, thank you. We have time for a couple of questions.
I ask a question, please? That's especially about congratulations to diversification. If we would have had time for a panel discussion, that would have been one of our big questions about diversification and what the issues are with that. And South Africa obviously is diversifying in a different way, like a lot of other countries will diversify probably more into the direction of TrueNAT. But what is your approach then to isoniazid resistance on the BD machine or the Roche? Are you going to do more testing on that, or you're happy with just saying this is then isoniazid monoresistance, and have you also actually changed your regimens then accordingly?
So there was a lot of discussion around this, and you have 3 different platforms. GeneXpert only has the rifampicin result. So the decision taken was that treatment is still based on the rifampicin result. We don't actually release the isoniazid result if it's sensitive, because there's no point, because the treatment regimens are based on the rifampicin. If, however, the isoniazid result is actually resistant, then those specimens would still actually be channeled into the centralized laboratory testing, having the expert XDR, because then fluoroquinolones would actually be available to guide the management.
So that means the second sample would be taken for isoniazid monoresistance if Roche or BD says isoniazid resistance, and then a second sample is sent to the centralized lab.
Yes, so that you could get the fluoroquinolone results.
And what is the proportion of samples which will be tested on the Roche and the BD? What do you think is going to be your distribution?
So Cepheid would probably have the lower of the market share, and the highest would probably be the Roche in terms of the really high throughput.
One question, Marguerite.
Maybe a comment? Maybe my voice is loud enough.
It's coming, it's coming.
Register, so it won't be loud enough. Thank you.
Yeah, I think those thanks a lot. That was a great presentation. I think in those discussions, it's really where it is interesting and important to step back and have also an approach which is less disease specific and more kind of centralized at the country level, because what might also shift the balance between using a platform such as the Roche Cobas is the possibility for integration and testing across many diseases, where you would use it not only for TB, but HIV and HPV. We're seeing more and more countries doing that as well. So that is also some of the elements you need to take into consideration. Thanks.
Yeah, in the program, the Roche Cobas have been used. It's been the mainstay of HIV viral load testing for many years. So it's really about integrating.
Any final question, Stefan?
So in your algorithm, you don't have any advanced molecular testing. Although I know that Shahid is doing that at NICD, so targeted sequencing, whatsoever. And BDMAX is also a fantastic system. But if you have your INH resistance RIF susceptible, there are already studies also from South Africa saying that like in the 20% range of those strains have RIF resistance that is not detected by GeneXpert. So have you discussed a way to to find that out in a kind of faster track for those samples being sequenced or whatsoever?
Yes, so there are discussions now in terms of where targeted next generation sequencing is going to be fitting in. And it's, unlike Cepheid, the BD, there's actually quite a significant amount of residual specimen that remains. So there are discussions on how to utilize and better utilize that.
It's nicely working. That is what I can say. So you can sequence from those specimens, and that works similarly. So the extraction efficacy is similar to the other systems, and targeted sequencing has more or less the same sensitivity from all of these. So you can use it at least.
Thank you. Thank you very much. So this it's 6 o'clock. Unfortunately, I think this has been quite an interesting symposium. We want to thank the audience and the presenters for this fantastic session, and see you around. Oh yeah, I forgot to thank the co-chair.